Uh, okay, great, great. So I think it's recording is okay. Yeah. How are things? We should. Can you still hear me? Okay. I just.
Yeah, should I get started or
Uh,
wait for a
yes.
little bit?
Yeah. We'll wait a couple minutes. I will just want to get the information up on
Okay.
my side so I can properly introduce you and then get started. Thanks. Thanks for me. I've already rescheduled once. I'm glad that
No, it's
this
totally fine. I feel like this is just kind of the season,
happened.
Things get really busy and there's a lot of traveling. I don't know, are you doing any fun travel this spring or?
Yeah, some conferences and um, yeah, right now I'm actually in Orlando for a clinical trial company as our conference.
Oh, that's really
So
cool. Okay.
cool. So I think we can get started. A lot of people coming in, and
All right.
many of my students are, because of the time change, probably will watch online. I do have
Okay.
a very large class, both the deep learning course and the big data course. And so I may just uh, get started. Thanks everyone for joining. It's my absolute pleasure to introduce you today's webinar speaker, Dr. Marzyeh Ghassemi. And Marzyeh is a leading force really in the AI for health community and is a inspiring voice for machine learning for healthcare, and also currently an associate professor at MIT for both in the EECS and also in the Institute for Medical Engineering and Science. Um, and she is really shaping the future of AI-driven healthcare with her research. And she also has great leadership, mentorship in this community as a whole. It's even started conferences in machine learning or healthcare type of venues. And so I don't have her full bio here, and I'm gonna not going to read that. Just to tell you some two fun stories
Oh
related to
no.
Marzyeh. No,
Oh
no, it's
no.
totally fine. Um, Many of you probably know that Marzyeh actually graduated from MIT as well. Now she came back as a professor at MIT, which is totally unusual, by the way.
It is
And
a little strange.
and then as vividly remember when I visit Marzyeh's advisor, Professor Pete Solovitz at MIT one time, and it was just very informal visit. I would just schedule anything. I don't remember I scheduled this talk really early on. And he insists I should give a talk. He said, okay, it'll be good to give a talk. And then I did that. And very few people show up, which is a little bit disappointing. But then two very important people in the audience are sitting quite close to me. That's Marzyeh and Tristan, and two of the
Oh, that's so
students.
funny.
Yeah, two of the students appeared at the time, and both of them are amazing. Asked a lot of interesting and deep questions about my work. So I remember her very well. That's one story. So, okay, this students was amazing. Asked such a deep question. I mean, you rarely see from machine learning students.
I know, right?
And second question, sorry, second story about Marzyeh. I think it's one of the workshop that you organized at some point. There were some technical challenge, I mean, issues. You were trying to introduce some speaker. I forgot the
I don't know.
full
This
story.
sounds like every single time I've tried to do something, there's always a technical challenge, but keep going.
And everybody in the audience have to wait because there was something not setting up properly, whether it's projector or something. And Marzyeh just standing there, said, oh no, and I can't imagine how someone can handle that situation, just stand there in front of hundreds of audience and waiting for the technical issue to be resolved. Then she said, okay, maybe I can tell you a joke. And she did tell a joke, and actually a technical joke, and
What
quite
was
funny.
the joke? I don't remember.
Well, something to do with Pascal or Newton. And
Really?
anyway, yes, you did tell a joke.
Oh my God.
That's
I tell
very,
jokes all the time, but now I really want to remember what the joke is. Wow. Okay. Very cool.
but anyway, so I know her for a long time, and I'm glad she said yes, come to our webinar to give this talk. I think to talk about ethical machine learning in healthcare. Thanks, Marty. The floor is yours.
Thank you. That was the nicest introduction I've ever gotten, FYI,
Oh,
to
thank
all of the students who are here. Like that's how you want to introduce somebody. That was very nice. Um, so I will now spend, the rest of my life trying to remember this joke because I don't remember what I said. It was too long ago. But today I'm going to talk to you about some of the work that we do in my group. I'm going to go through the first part of the presentation pretty quickly because it's older work. And also I think you all are on the same page. You know how to, do machine learning broadly, and you're interested in health, at least reasonably, I would assume, to be here. And I'll focus on some of the newer work later on. So my group at MIT is the Healthy Machine Learning Lab. We have 3 focuses or foci: evaluating needs in health settings, constructing robust models for fair results, and understanding machine learning deployments if we make them. The demonstrative example that I always give, because this was a big turning point for me as a researcher, was when we were approached by clinicians with a realistic problem that they were having. If you've ever been to a hospital when it's busy, it's no fun to wait around in a waiting room. And there's real risks to waiting in a waiting room as well. There's used to be COVID, there's MRSA, there's SARS, there's, HN51. There's so many different things you can catch in a hospital. And the reason that you go there is because often you have something more important happening and you just want a clinical opinion. And so in this example, we want to make sure that if a patient is having trouble breathing and they've had a chest x-ray and a doctor can't see them for a while, we can build a model to try to triage those patients. So specifically to say, these patients are healthy, they can go home. Everybody else, I'm not certain, have them stick around for a little while. And we just ran this pipeline, which is the pipeline that everybody runs in machine learning to develop a model and deploy it. We've already chosen our problem. We want to build a model to do chest x-ray based diagnosis for this triage setting. And when you run the rest of the model, you can pick the 3 large chest x-ray data sets that are publicly available, over 700,000 images. You can train a dense net to predict no finding, which means the person is healthy, and you can get really good performance. But obviously this is not new. This is not unique. This is a thing that people have been doing for a while, where you, pick a prediction task, you get a data set, sometimes small, sometimes large, and you report a single number. And it works well. It works well on a large number of tasks across the human lifespan. But I think the issue is we're now deploying these models. And we're not just deploying a few of these models. RIP now, who knows what's going to happen with different agencies, but at least in October of 2024, we had a very large number of AIML enabled medical devices that had been authorized by the FDA, primarily in radiology, but across many different subspecialties. But I want to ask a different question. Now that we've all figured out that we can do this, the question is, should we do this? I think that's a question that machine learning researchers should be asking themselves more often than we do. The reason why we might not want to do this in this case is, yes, we have state-of-the-art performance, and it's really high. 0.859 is pretty good. If you compare the false positive rate of this model in different subpopulations, we wouldn't want it to be significantly higher. And the reason why is this is like an underdiagnosis. Because if you falsely positively say that somebody is healthy, that means they're actually sick, and you've sent them home when they're actually sick and they need treatment. And when we run this audit, we find that it has, our state-of-the-art model has the largest underdiagnosis rate in female patients, young patients, Black patients, and patients on Medicaid insurance. And if you exist in an intersectional identity, you're doing much worse. And this is not ideal, but systems like this are already deployed, and they're not just deployed for neural networks are sort of old news now. Let's talk about transformer models, right? So old news now, because this was announced in March of 2024. The GPT-4 transformer model has been integrated into Epic's EHR software. At that time, it had drafted over 150,000 notes and multiple millions of messages between patients and providers. But when we did an evaluation quite a long time ago, because this is something doctors have wanted for a very long time, just write my notes for me. It takes a lot of time. When we did an evaluation of SciBERT, which is a kind of transformer model that's supposed to be less, virulent, less hallucinatory because it's trained on scientific PubMed abstracts, it completed the sentence, Caucasian patient became belligerent and violent, or white patient became belligerent and violent, with they were sent to the hospital. But if you indicate a minority identity with the same context, it says those people should be sent to prison. And again, these are deployed systems. These are systems that are being used in the world because humans want decision-making aids. We want systems that can help us figure out what to do. And we're more focused on efficiency in processes that are currently flawed than revamping flawed processes. So I'm going to walk you through a few examples in each of these stages of the pipeline. I'll go reasonably quickly through many of them. And if you have a question, you can raise your hand. Or I'll also pause for questions at the end. So the first reason you might believe that your model might not be acting ethically is because of the data that you have. And indeed, we have a couple of papers that were published in 2022 that show irrevocably that you could predict things like so demographic information like self-reported race. Or a patient's age, a patient's gender. But self-reported race is actually fairly implausible because humans can't do it from notes or medical images, but machine learning models can. Okay, so machine learning models have this superhuman capacity. They can do something that humans can't do. And a reviewer, when we published these papers, several reviewers said, so what? Are you making sort of a bigger deal of this capacity than you should be? And we wanted to set out to evaluate this. And so we published a paper last summer trying to understand whether demographic shortcuts that only machine learning models have access to matter. We're going to look at 3 different settings where we have medical imaging data. So this would be ophthalmology, dermatology, and radiology. And in all cases, we're going to train a machine learning model to predict a clinically significant problem so different tasks in each of these areas. We're going to first train with ERM, empirical risk minimization, which is our vanilla optimizer in most settings. And then we're going to test the model to see whether it's learned while it's being trained to predict clinical things, these other demographic attributes. So we run this evaluation training dense net models, which are kinds of convolutional neural networks with ERM. And we find that these models trained to predict disease do encode demographic attributes. And which is known, we already showed that in the 2022 papers. But here, importantly, we demonstrate that the greater encoding of such demographic attributes is correlated with larger disparities along prediction performance within those attributes. Put more succinctly, if the more I learn to predict who is female when I'm predicting retinopathy in ophthalmological images, the worse I will do at predicting retinopathy in female patients. Those 2 things are correlated. Okay. And there are ways that you can address this, right? ERM is not the only game in town. We actually have a large suite of different subsample, subgroup robustness, group adversarial, and general robustness methods that people use now. And so, ERM models are clustered all the way over here where they have a very high average performance when you're only reporting that one number. But when you look at the fairness gaps between any 2 groups, here we're grouping people across age, but you could do it across sex or race or any combination, right? So ERM models often concentrate, not always, but often concentrate in the upper right-hand corner, right? So they do well on average, you get sort of one number, but then they have really high fairness gaps. And you can see here, we've plotted this Pareto front, which is an economist sort of a graph to show the trade-off between any two things. And so here, if you picked any of these models, and each point is a model that operates along the Pareto curve, you could say it's optimal for some value of optimality. So for example, you could pick, this model if you wanted something that had a slight decrease in overall fairness, or sorry, in overall performance, but very, very low fairness gap between any two groups. You could pick this model if you wanted to nudge your overall performance over, and you were willing to tolerate a slightly higher performance gap of 5%. But this is all of these models. And in all cases, we're able to find good models, which is good. This is like really good news. It was a very happy result. But this is all in the context where we're training models on data from one setting, Massachusetts. And then we have data held out from the same setting from Massachusetts, for example. But that's not actually how models get trained, right? Like what happens is I download the MIMIC data set, which is in Massachusetts, and I train a model based on that. And then I deploy it in a new place in California. And when you do that, actually what happens is models that are Pareto optimal are not guaranteed to be Pareto optimal. And so all models become worse when you evaluate them in a new setting under distribution shift. So for example, from Massachusetts to California. But some models degrade more than other models. And importantly, this is not a predictable attribute. So your Pareto optimality, whether you hold it, is not something you are easily able to predict. And so what this means functionally is that you do have to test models in the populations in which they are going to be deployed to, because there's no guarantee that if they work well in one setting, they'll work well in a new setting, even if it's similar. I mean, these are sort of, we think of like health systems in California and Massachusetts as being very good. These are, sort of coastal elite places. But here the performances don't hold. And this was true both when we tried to look at different optimization metrics that encouraged fair and distribution results and different modeling strategies. So that's the data collection portion. I don't see any raised hands. And so I'll quickly, go through the rest. Let's say that you've collected the very best data that you can, and now you need to label that data, okay? Labeling is often, I think, this sort of forgotten part of what we do that's sort of simple and, because it's binary, right? So my kids go to a school that has a meal code, and the meal code prohibits high sugar content in meals. And so if I wanted to build a machine learning system that looked at pictures of people's food and then made a prediction about whether it was okay or not, for them to bring it into the school, the way that I might do that is I would take, this picture, and I would take a bunch of smart people like you, and I would have you vote whether this meal has high sugar content. And so can you see this photo like reasonably well? If so, by a show of hands, everybody go to your reaction. And if you think this meal, we're going to do this live. You're going to label this live for me. If you think this meal has high sugar content, raise your hand. I guess in the emotion or the reaction thing. Okay. I'm seeing several hands get raised. Okay. Not most people, actually. Most people do not think so. I'm seeing like 3 or 4 hands get raised. So since very few of you think this is high sugar, this would not get labeled as a high sugar meal. Like we would tell the algorithm not to predict that this is high sugar. In practice, you guys are very unhealthy because this is a high sugar meal. This has like whipped cream on it. These are Cocoa Puffs. This is a very sugary cereal. So congratulations to the people who voted yes. But no matter how you labeled this, we would be labeling it in sort of a fake way. What I mean by that is I asked you to label this in a binary way, asking if it has high sugar or not. But I didn't ask you if it violates the school meal policy that prohibits high sugar. And because you are reasonable people, you're saying those are the same thing, right? Like if it's high sugar, it violates the school policy. But 17 out of our 20 labelers said this had high sugar, and only 2 out of 20 labelers said that it violated a school policy that prohibited high sugar. Why? What's going on here? It's a little bit confusing, maybe, right? Like we might be wondering why. But it's not just in the meal setting where this is true. So we tested this in 4 different settings. So what we found is that if we asked if somebody's outfit had high skin exposure, people said yes. If we asked if it violated an office policy that didn't allow high skin exposure, they said no. If we asked if a dog was an aggressive breed, they said yes. If we asked if it violated a building policy that prohibited aggressive dogs, they said no. If we asked if a comment was negative, threatening, or obscene, they would say yes. If we asked if it was in violation of guidelines for the forum that said you can't have negative, threatening, or obscene comments, they said no. What's happening? And so here's something to think about. Just think about for a second. When we ask people in medical or non-medical settings to label something, we always ask them to describe whether the feature exists or not. Is the dog large? Is the meal sugary? Is the comment threatening? But when we build systems, we build them to automate normative human systems and judgment. We're not just predicting that dogs are large for the fun of it. You're training a system often to be used in practice to automate some sort of human judgment. And the problem is there's a well-known legal sort of thing about phrasing, which is when you ask somebody if a dog is large, the bar for what is large is here. When you ask if a rule has been violated based on the dog's largeness, suddenly the bar for what is large shifts in your own mind. And so the way that we decide whether factual features are present in an image as experts and non-experts changes when we know that there are consequences for the judgment of that feature. And that's really important because we only ever gather labels like this, and we only ever use them like this. And so we wanted to say, what kind of systems are we building now that we know that we're doing this? We're only gathering data like this and only using it like this. Where we're building systems that in general are much harsher, because machine learning models that are trained on repurposed descriptive labels and applied to normative tasks have much lower performance due to their higher false positive rates. They're saying that all of those dogs that we don't think are actually large in the context are large, because that's the way that you gathered your labels. And when you look at this error rate, it's actually like pretty reasonable. And so it does impact model performance. Oh, I see there's a question that says high sugar for whom, like for children, is it okay? In this setting, we're doing it for a school. And so it's for children. And so the assumption is it's not okay for children to eat high sugar in this setting because it's a school rule. I'm going to go through, I think there's a reasonable amount of content in algorithm development. And so for the time being, imagine that you've done a pretty good job collecting your data and defining your outcome. And now you just want to build a model to optimize, right? Well, one problem that often comes up in a healthcare setting is how do we use group attributes in prediction? And this came up way before machine learning. This has nothing to do with machine learning. In sort of the classical AI setting where we were just building logistic regression models, this still existed. And there was a very specific thing that came up and that is still being sort of deconstructed today, which is we know that if you use group attributes like sex, age, and race in a clinical risk score, it can result in worse performance for a subgroup, even though it's guaranteed theoretically and empirically to improve performance or not change it overall, right? Because if that feature was a bad feature, the model would just not choose it during optimization. And so in this example, if we train the logistic regression model to predict sleep apnea and we include sex and age, it's worse for younger male and older female patients, even though it's better on average, okay? Why is this happening? This happens for 2 reasons. So the first is this could just be model misspecification, which means this model is not high capacity enough or does not have enough data examples to capture the necessary interaction effects between a feature and a group attribute. Okay, like those 2 things interact, whether you are female or male interacts with a specific feature like height or weight in a way that the model can't capture. Okay, and that's also important for prediction you're making. Another thing that happens is ERM, right? So if you use hyperparameter tuning that optimizes for overall performance, like empirical risk minimization, you're literally just telling the model do best overall. And so it's going to, even if that comes as a result of harm for one subgroup at the benefit of a larger subgroup. And so we actually have an ICML paper that we presented 2 years ago in 2023, trying to understand when and how to use different kinds of clinical information that is, personally relevant in clinical risk scores. And so we have a demonstrative example of should we use race to predict mortality in acute kidney injury patients in the ICU. And so the first thing we ask people to do is to use a group blind classifier. That means, for everybody in this call, all 17 of us, I'm going to train one model to predict this outcome, and it's not going to have access to our group information. So those features won't be included. It's group blind. It just doesn't know. Okay. But even though the model doesn't know, I still know what our groups are. And so I can still show you what the performance is for each of these subgroups. Okay. The next thing I'm going to do is try all the way on the other side, a decoupled per group classifier. That means I'm going to train one model for each of these different 6 subgroups, one for Black female, one for white female, one for female other, one for Black male, like one for every subgroup. Obviously, this doesn't this explodes once you get into more intersectional group identities, but for the time being, let's just look at these identities. And what we find here is that across the board, we tend to see improvements across these 3 different interventions, across these 3 different metrics across all groups, right? And so it's either no better or slightly better to use a decoupled per group classifier, right? And so this means if you could just train one model for each subgroup, maybe you would do better in this case. And then we're going to compare that to what would happen if I just trained one model for everybody, but I included race and gender as variables the model had access to. And here you can see that using race and gender in a model, one model for everyone, leads to worse performance across all metrics for Black men. And so this is not something we would want to do. We would either want to do a group blind classifier or a decoupled per group classifier. But importantly, in the paper, we highlight that there's no one solution that resolves all of these fair use violations. You just have to run the test and see for my prediction task, for the data I have, for the class of model I'm training, does it make sense to use this or not? And that's just using very simple models. We don't use very simple models anymore, right? At least in general. Now we have vision language models. So vision language models are these flexible models they map words to images. So maybe you've seen this. There's these image generation sort of settings where we have things like Midjourney or DALL-E, and you say, I want a photo of a doctor. It passes it to one of these services. They use these conditions that you've put in the image, pass it through a diffusion model, and that generates a picture of a doctor. And it's not just image generation that people use things like Midjourney or DALL-E or any of these other multimodal vision language models for. You can use it for zero-shot classification or for zero-shot retrieval. But the problem is in all of these settings, we also know that there's really problematic biases in image generation and zero-shot classification and in zero-shot retrieval. And these are things that we don't want to be true if these models are going to be used in practice. And the way that people tend to do debiasing right now is they make a sort of assumption that some of these concepts are linear. So for example, if I want to debias a vision language model with respect to a specific protected attribute like gender, I assume it lies in a linear subspace where I can, estimate where is male, estimate where is female, and then orthogonalize and project out those distances so that I have some parity in generation. But the problem is that's not actually what these models look like. These models actually are really complex nonlinear embedding spaces. And so the direction for male and female doctor could be very different from the direction for male and female pilot or manager. And so we have a proposed approach to try to do bias elimination in a nonlinear way. And specifically, we have some things that are important in this setting. We want no fine tuning of the vision language model in order to achieve this. We want to tailor the debiasing operation for each query, and we want something that can be applied at test time to unseen queries. And so the way that we do this is by building on the existing linear approach. So let's say I want to generate a picture of a doctor. So I ask for a doctor, and then it lands in this part of the embedding space, primarily around male photos And I've drawn this line between purple and green to show where male and female might be classified. Well, I can first do this textual debiasing step that people often do, which is, again, this linear orthogonalization and projection, and move the query of doctor from this point in the embedding space to this point in the embedding space, existing on this boundary. But as you can see, because this boundary, is already sort of biased in this complex nonlinear way, I'm still much closer to photos of male doctors than female doctors. And so instead, I need to do something a little bit different. I can use this boundary, the separation point, optimal separation point between male and female, but then I need to move along this boundary until I'm at a place where I'm equidistant between support or samples in my embedding space that are both male and female, if that's the attribute with which I am debiasing with respect to. Okay. And by doing this, we're basically finding an embedding that has an equal distance to each attribute group and a minimal distance from our initial embedding, because we still want it to generate doctors. And the nice thing about doing it this way is we have an analytical solution to this optimization equation to find this embedding point, because these are two constraints that you can easily encode. Okay. We do a bunch of experimental evaluation with respect to other baselines in a few different data sets. And we find that BenVLM does better at decreasing bias with minimal task performance decrease in both classification and retrieval. So that's a good thing. But we also found that there were some examples that were very hard to debias, and it had nothing to do maybe with the complexity of the case. Instead, and this is a new project that we're working on, it had something to do with negation. So despite their flexibility, vision language models struggle with negation understanding. And if you've ever used, like, again, DALL-E or Midjourney or any of these other stable diffusion models, what'll happen is you'll say, I want a table filled with food, but there's no chairs for the people trying to sit. And you'll get an image like this, where there are lots of chairs. Okay. And this is not just true for image generation, it's true for image retrieval and for visual question answering. Vision language models are really bad at negation. And maybe this is, not such a big deal when you're asking for a dog with no grass, but it's really problematic in clinical applications that require explicit inclusion or exclusion criteria. So for example, here, if I say that I want to retrieve images that have evidence of lung opacity, then I want this. But if I want evidence of lung opacity with no signs of edema, then I don't want this. Right. And so understanding negation becomes really critical in healthcare settings. And so we wanted to try to understand, again, why is this so bad? It's bad for two reasons. It's bad because when you are describing a natural image, you do not often describe what is absent. If there's a picture of a person in a kitchen, we often don't have this thing I've added here, right? At the table, there's pies being crafted. A person stands by a wall adorned with pots and pans. And noticeably, there's no fork, right? That is not how people write captions. You would not say there's no fork. Who wouldn't even notice that from this image? And so the problem is we don't actually have good examples in contrastively trained vision language models of how negation tends to work in natural language, okay? And so we actually built a benchmark to try to understand just how bad are all of these state-of-the-art vision language models. We did this by looking at image and vision data sets, extracting positive concepts, using open vocabulary and object detectors. And so we would look at whether there were certain images that had or didn't have, for example, orange juice with a straw, orange juice with no straw. And then we created, using an LLM, paraphrased versions that sound like a person saying that there is, for example, orange juice with or without a straw in many different ways. And so in this way, we have sort of these natural captions that we can test our model with. And so we looked at state-of-the-art CLIP models. CLIP is this leading, vision language model, contrastively trained embedding space. And we looked at two models that are specifically trained to handle negation. And all of the models we looked at really failed to understand negated examples, both in retrieval and in multiple choice question answering. So specifically here, you can see that in retrieval, for sort of the mild examples, we see performance losses between 4 and 7%. When we look at hard examples, the losses go much higher, over 20% in most cases. When we look at multiple question answering, the performance results are pretty bad. But what's even worse is when we look at medical vision language models. Here we see performance drops that are between 20 and 30%. And again, this is in, ConsciH here is a vision language model specifically trained for chest x-rays to include negation. And we're still seeing drops like this. And we wanted to understand, what is happening, right? And so this is a T-SNE visualization of two different models, one that is just the vanilla clip and one that is neg clip. So neg clip is trained to understand negation supposedly. And here we've projected affirmations and negations of many different classes of objects. And so if you see a yellow circle, that's a sentence, there is a flower. If you see a yellow triangle, that is, there's not a flower, right? Or here, if you see a gray circle, that's there is an elephant. If you see a gray triangle, there's not an elephant. And where are we seeing clustering here? In the colors, right? So that means that affirmations and negations for the same object are embedding right on top of each other. That means there is a cat looks exactly the same as there is not a cat in these models, which is not ideal. This is not what we want, right? And when we look at, again, even contrastively trained vision language models, they're supposed to specifically do well with negation. They do sometimes really silly things like ConClip here does a really good job of separating out all of the circles, right, into different classes, but it embeds all of the triangles here in one fixed point. And so this is a flower, an elephant, a bicycle, a person, a car, and this collapsed portion is not a flower, not a car, not an elephant, not a dog. Every negation is right in one place. And so, let's assume that we, so there's definitely drawbacks and ongoing performance tuning that is necessary in these vision language models, right? We have, these systems that seem really, really fancy and can do really great, technically admirable things empirically, but they have specific flaws that maybe are counterintuitive and that we really need to address. But that doesn't stop them from being deployed widely, right? So we had a few examples before. Another place where large language models are being deployed quite a bit is with chatbots in healthcare settings. And that's to help people who are going through mental health crises or to help people who are helping people going through mental health crises. And so we wanted to do an evaluation of what happens when you have flawed or biased large language models giving advice to humans helping other humans. And so here we took the transcript of a mental health crisis line call, and we asked a bunch of doctors and non-doctors to make a simple decision. Should we send for emergency medical help to a caller's location, or should we contact the police for immediate assistance? And importantly, we gave them some training. We said, first, we need you to assess if there's a risk of violence in this record. And then if and only if there's a risk of violence, call the police. Okay? So we're asking people to make a factual assessment and then a decision based on that factual assessment. And in the control group, you get no advice. You just look at this transcript and you make this decision, okay? And then we have the treated group. The treated group was randomized to either get a good GPT model or a racist GPT model. Okay, and if you got the racist GPT model, it was very racist. It almost always said that you should call the police on minorities. Okay, so if you're in the treatment group, that's treatment number 1 that we randomized. Treatment number 2 was we randomized whether we gave you the advice as the factual feature assessment, there is a risk of violence in this record, or the recommendation of what to do. Our model thinks you should call the police. And importantly, these are equivalent because it's if and only if. If there's a risk of violence, then you should call the police. And you should only call the police if there's a risk of violence. And so while these two things are giving you different content, this difference in treatment is just varying the style or the medium in which you get the message. Okay? And so we wanted to look at which of these two treatments actually made a difference. And so first, when we look at our subjects at baseline, we find that respondents are not more likely to call the police on Black and Muslim subjects. That's really great. That means that, you know, if you give them no advice, clinicians and non-clinicians do not disproportionately call the police on minorities. Great. We found, however, that if you give both doctors and non-doctors biased prescriptive advice, meaning you tell them to call the police on minorities, they tend to follow that advice more and do it more. But importantly, when you give them the same bad advice from the descriptive model, when you say that the AI system has flagged this call for risk of violence for minorities more, it does not have the same effect. And so even though you're giving them worse advice, the fact that you're giving it to them as a factual assessment is protective. They don't listen to it. But when you give this result to people as a suggestion of what to do, they listen to it more and they follow the racist advice. And this has really important implications for, you know, models are going to be wrong sometimes. They're not going to be as racist as the model we trained on purpose to be racist, but they'll still have problems. And some people have said maybe we should fix these gaps with model-based explanations. But the problem with explanations is that other work has shown that people tend to trust advice when it's explained more, even when it's bad advice with obvious mistakes in it. And so rather than just explaining the systems to an end user, I think it's important that we start to build ways to verify the systems that we're giving to people. And this is already familiar in medicine because we have a lot of tools that people don't know. Either we just don't know scientifically how they work. We don't know how acetaminophen works or lithium. Or, you know, most doctors do not know the details of how an MRI machine works. They couldn't service it if they needed to, if it had gone, you know, out of distribution or out of service. But they have a service contract where they know that something has to be well calibrated, and they know that there's a system to do that calibration, and you know, a set of technicians who can do it on demand. I'm going to wrap up since we're close to the end and try to summarize my views on this more generally. So my views can be stated in sort of four sentences. So my first statement is, I think the problem is that AI is biased because we are. Okay, like if somebody tells you that they're worried about AI killing them in a healthcare setting, you should ask them why they weren't worried about doctors killing them before the AI was trained on the doctor's data. Because this has been happening for a while, right? There's a great paper that came out from David Bates last year where he showed that if you take a random sample of almost 3,000 admissions in Massachusetts hospitals, there's at least one adverse event in over 20% of those admissions. Of those, over 20% are preventable adverse events, meaning a human made an error that shouldn't have happened and it hurt a patient. And the severity level of those preventable errors was serious or higher in over 30% of the cases. Okay? And when you extrapolate this from Massachusetts to national samples, ARHQ estimates that there are over 7 million US emergency department patients that are misdiagnosed, and over 2 million patients annually suffer an adverse event as a result. These are not small numbers. But this is what we're training our machine learning models on. These are the gold standard labels, right? So that's one problem, but there's maybe a bigger problem. The problem is biased AI can still be very efficient, and that's why it's already being deployed. So even though there's biases, even though our gold standard labels are maybe not that golden, we're still using it. And there's many examples of deployed systems because it saves money, it's more efficient. There was a recent poll of a few hundred medical group leaders, and they found that the most common uses of AI in clinical settings were these sort of non-clinical adjacent tasks like patient communication, clinical documentation, improved billing. The problem is when you use models in clinical settings for non-clinical tasks, it basically skirts all regulation, all peer review, and all approval. So when you use GPT-4 to complete patient messages, it doesn't fall under the purview of most federal regulators. It does not require ethics board approval, and it hasn't been peer reviewed. And as we're seeing now, this is, you know, obviously there's much more violent headlines now that we could cite, but Cigna as a company was sued, in the state of California because it was using allegedly algorithms to deny coverage to patients. And the evidence looks pretty damning. So they were just denying thousands of patients' claims at a time. It's efficient. Who cares if it's biased? It saves them money. There are many post hoc fixes that we can think about, like disclosure, evaluation, regulation, and I'm a big fan of all of those things. We also have to recognize that there's limitations to each of these, right? So like models are regulated advice givers, you might say, which was true. But there was a study in 2022 of the FDA-approved AI tools, and they found that only one of the tools they examined out of all of them was trained and or validated using data sets that included US representative groups. The average size of the validation set was only 300 patients. That is small. Okay, I'm telling you now, that's a really small sample, at least in my community. And almost all of the devices were assessed using only retrospective studies, no prospective evaluation. And importantly, remember that first result I showed where, the results in Massachusetts didn't replicate in California. Most of these devices are not reporting multi-center assessments. They're showing it works well in one place at one time. So I think there is sort of a pivot that needs to happen here. AI can be a really transformative technology, but it needs to be transformative because it extends human capacities, not just automates these inefficient, biased things we already do. And so I think there's some really nice examples of this, where, for example, historically, we've been really bad at doing robust breast cancer risk assessment across women from different backgrounds. And there was this really, really great model that was trained by a fellow MIT researcher, Regina Barzilay, where she just went and she literally got hard drives of data from international collaborators of imaging of women from different backgrounds and their breast cancer to build a better risk stratifier for breast cancer. That's not something humans were good at. They weren't good at looking at examples of dense and non-dense breast tissue and creating adequately stratified risks for women. And it's a fantastic thing to have now. I am senior enough that I remember when PhD students tried to they tried to predict protein folding and structure matching with these hand created rule based algorithms. Nobody thought you could do what AlphaFold can do. Humans can't think this way. We don't understand how all of these biochemical physical processes at these tiny levels interact and create structures for proteins. And machine learning models can do this. That's really cool. Right? This is not just saying I'm going to take something humans do in a poor biased way and make it efficient. It's giving us capacities that we didn't already have. And I think that's the way that we need to move forward in machine learning and health. We need to move, sort of beyond what we do right now and towards improving care. And I think there's a few generalizable things that have been shown in the past 5 years in health specifically, which are the losses that we will suffer from bad AI are much worse than the gains we will get from good AI. And so at a baseline, before you even think about deploying something, make sure it's very good. Number two, doctors, and therefore I think most experts, are very susceptible to incorrect advice, even with expertise. So make sure that you have ways of delivering advice that acknowledge that humans tend to be susceptible and have cognitive biases. And number three, the way that you deliver content can matter more than the content itself. That was this study that we looked at. And so think not just about what you're predicting, but how you're delivering the prediction result to your end user. And I think, in order to move forward with ethical AI in general, but in healthcare specifically, you really need to think about that throughout this entire pipeline. So considering source of bias, evaluating models comprehensively, and recognizing that not all gaps can be corrected. But if you, think carefully about it with a fantastic group of students and collaborators, both, technical and clinical, I think you can move forward with creating actionable insights in human health. Thank you.
Thanks. This is amazing. Now we still have 10 minutes to ask questions. If you want, you can ask directly or post it on the chat.
I see a raised hand.
Yeah, hi. This is Anushree. I'm based out of Dubai, but I worked for solutions in the Indian market. Thank you so much for sharing everything that you did. It's very insightful material. I was in Arab Health last week, and we were sort of discussing a lot of solutions around the space. My question is based more on solutions that can impact my market back home in India. India has one doctor for every 1,000 patients. And the kind of sort of clinics we go to, we get maybe 30 seconds to sign up patients and 2 minutes for face-to-face time with the doctor. So, and that's typically what the patients is gonna, 2 minutes of time, like probably in the whole year is what they would get to
Wow.
sort of just meet the doctor.
Okay.
And ethnicity is something, ethical solutions is something that is a big factor for us. And the second problem that affects us is biases, because when we use foundation models that are trained on data which is not Indian medical data, we find the solutions also don't work for us. Something that does work for us is creating sort of agentic frameworks that can benefit from local data. So if you have data for a doctor, maybe who's sort of, let's say, just a breast cancer specialist, but has relevant data that's been around for him for the last 6 months or a year for the patients that they've been seeing. And if we also have data from that person's sort of history, then creating RAG systems out of that using, all the RAG technologies that we have, available in the market, and orchestrating a framework out of that with the foundation model gives us better responses. So I just wanted to know, what are your thoughts on that?
I think, like in most, human settings, there's no perfect solution. Everything is a trade-off, right? In all human settings, everything is a trade-off. I think that the question is, do you believe that a foundation model that is giving advice in some settings, or giving, some low-level access to resources in some settings, has a significantly higher propensity to do good, even with the current bias data it has and bias, actions it's going to mimic, than the harm it might do? And I think in some settings that's very plausible. So for example, there are some diseases in the United States that don't get diagnosed for like 10 or more years on average. The average is 10 years for diagnosis delay. In those cases, I'm actually a strong advocate for allowing AI, ML, and whatever you have. If it's better than that, let's try it.
Yeah.
Because it's not going to do worse than what we are doing right now. But I think it's also very important that you test that assumption, right? And so I think the problem is often what I see is, somebody sort of buys a foundation model or AI solution and it's applied to everything. And I don't think that that really makes as much sense. Healthcare tends to be very fragmented. I'm not as familiar with the way it's delivered in India, but in the healthcare systems that I've been a part of, often your primary care provider is a gating function of some kind, right? And so there are resources often that exist somewhere, and you need to get somebody, often a primary care provider or a general practitioner, to sort of vouch for or do an initial set of evaluations to give you access to that resource. And I think that that's a very plausible thing that we could imagine doing system level tests on. So I know, for example, in the UK, there's a couple of, there are very few radiologists in the UK compared to sort of the population that needs screening for different cancers. And so I know that they certified a couple of different screening algorithms for breast cancer, such that because if you have a scan, a mammogram, and you have one radiologist sort of look at it, you can have the AI be the second opinion. And what happens is, if the AI agrees with the radiologist, it's instantly fast tracked. Like, you don't need to wait another month. You can just get this person the resources they need. They can get early screening, right? If there's a disagreement, then you have to go out, wait the extra time, and get a doctor, like a second opinion, right? Because usually their protocol is 2 people need to review it. And so I do think that there's ways of using like a human system in conjunction with some AI assistance to accelerate access to resources. I think we also have to be cautious, right? We don't just want to apply it and say, well, the kinds of people who have access to medication now, they're the kinds of people who are going to have access to medication forever, because that's just what the model learned is the kind of person who gets access to a medication, for example.
Yeah, I thank you so much. I agree completely. I think there are so many pockets of use cases that can be sort of debated upon. There's definitely use case in for us in knowing about the patient's history from birth to wherever the patient is, and of course for the doctor. So yeah, I think a lot of other people have questions, so maybe we'll pass on. But thank you so much for sharing your insights on this.
Great. So we can take a couple more questions. Pranav, you want to go next?
Yeah, thank you. Love the presentation. Thanks for all your time. I had a quick question around, like specifically with those lawsuits where they had like small data sets for representational or for like intersectional groups. I was
Yeah.
basically wondering, is that like a problem that we could tackle with like synthetic data, where we basically try to like generate like more data within that, or does that itself create like an ethical issue? Basically, like, I don't know, faking
It
people.
sort of depends on the setting. So I don't mind saying that I think there are a couple. So I am generally a synthetic data skeptic. Okay, so I want to disclose that bias like ahead of time. And that's because some of the prior examples that I saw in other settings of synthetic data did a very poor job of matching the data generating distribution, and especially poor job in minority examples, because it's hard to estimate a distribution that you have like this many examples of, and it's a big multidimensional thing. Recently, I have seen some reasonably good papers, I think reasonably strong suggestions that for some cases, so the example is, I think it was Mohammed Norouzi's group in University of Toronto and Google DeepMind, I think, where they showed that, you know, if you're trying to simulate pictures of rare songbirds, we've seen so many pictures of birds. Foundation models know what birds look like. Okay, we've seen them everywhere in all settings. There's so many examples of birds that it's actually pretty good. Like foundation models are very good in a tunable way at visualizing a rare songbird in new environments, right? So like, for example, songbirds environments are being depleted, global warming. We used to only have pictures of them with green backgrounds. Now we need to be able to recognize them with brown backgrounds, but spurious correlations are really hard. This is such a perfect solution. It's saying, we know we need more examples of this very rare sort of target of interest in many different settings. And we know, we, meaning like large foundation models, really know how to generate all of the backgrounds and the foreground so well that the combination is high quality enough that they show downstream prediction improvements is very good. Okay. So I was very impressed by that paper. It changed my mind about the possibilities. The results in clinical settings have been more muted. I have seen some good papers, I think, trying to do something very similar. For example, simulating different kinds of skin conditions in different skin tones, or different injuries to a ophthalmological image in different lighting settings for low resource settings. It's just not as good. And it's because we do not have the same huge amount of internet crawling data that is supporting this model's very strong prior knowledge of what birds look like and what backgrounds look like for ophthalmological, dermatological, radiological images. It just doesn't exist yet. And so I think it could be there, but I don't think it's there yet.
Yeah, that's actually one of the questions I wanted to ask, but I'm glad Pranav asked that already. So we have a recent paper coming up from NPJ Digital Medicine that's kind of actually used the EICU data. And if you think about synthetic data as a more advanced version of rebalancing, right, up sample, down sample, and we actually see some improvement on improving the minority groups' performance without sacrificing. I mean, I think It's not out yet. I have to confirm the final correction, but it's coming up. I'll send you that paper. It's kind of interesting. You mentioned that you think that synthetic data could be useful if we have enough samples, right? I guess diverse samples to create the realistic minority patient records. And
I really do. I feel like, you know, it's such an issue right now because we have this gap of we just don't have enough. And so I think it is an exciting area where I'm looking for more innovation to happen.
so I know we're kind of run out of time. Do you have more time to answer a couple more questions, or
I could probably do one more. I have to teach at 2:30, so I need to run in
One
about
more.
5 minutes.
Yes, this will be I always ask our speaker to give some advice to our some of our students, some of our general audience. And in your case, I mean, I'm super curious because every machine learning researchers, good researchers can very good at developing methods and proposing new algorithms. I mean, so does Marzyeh and her students. But one unique thing I saw from your group and for a long timers, you have a lot of very interesting. You're very good at picking problems and interpreting results, right? To tell a very compelling story. And can you share your secret here? How did you pick those problems and find those interesting?
So this is sort of a life skill, and I would encourage, for those of you who don't know, I had sort of a very roundabout journey to where I am. I went to a state school, New Mexico State, very small. It's not a nice school. It's not a fancy private school. But I really enjoyed my undergraduate education. I got a scholarship to go to Oxford. I had my first child when I was a master's student, like right before I defended my master's thesis. I came to MIT with a 7-month-old, and I had 2 more kids while I was in the PhD program. And I can say with great confidence, there are very few people I have met who sort of have similar backgrounds. And one of the things that I think is very helpful for me is I've seen many things in my life that are easily translatable into understanding why a problem might exist. Right. And so there's like, I don't know if anybody here is a poetry fan, but there's like Iranians love poetry just in general. I'm Iranian American. And there's like this great poet that Iranians often quote. And he says, you know, if you want to like be a good person, you know, you need to repent from your sins, but first you have to go sin. Right. Which is not in any way advocating that anybody here do any bad things. It's saying, if you don't even understand what the problems in the world are, if you haven't seen anything, you can't fix it, right? And so I think part of what motivates me to pick specific problems is I've seen these things happen. I've seen people be denied health coverage. I've seen chronic diseases go longer than they should for bad reasons, right? Reasons that shouldn't exist. And when you know that things can happen, I think you're looking out for them maybe a little bit. And so I think, you know, I know that as scientists, we're really encouraged to, you know, try to separate emotion and logic, which I think is reasonable. But I think it comes sometimes at a cost of removing your perspective. And so I don't think you should remove your perspective. I think perspective actually helps in the selection of important problems. And for framing your results, that is, I come from a relatively large family, and I have 22 first cousins. And yeah, I know. And I had to babysit a lot as a teenager, as you might imagine, right? And, you know, if children are fighting, I don't know if anybody on this call like has children. I know Jameel has children. So like when kids are fighting, you know, what is a way to stop them from fighting? You just tell them a story, but you have to make it engaging enough that they want to know what will happen next. And that's true in life generally, right? Like if you want somebody to pay attention to you or you want your results to get noticed, you know, it's not on the world to like notice that you're amazing, right? Like, it's not like their problem to see that you're great. Everybody's busy. Everybody's got their own lives. Everybody's got their own problems. You need to tell a story that's interesting enough that when you read the first part, I want to know, well, what happened next? And I think that's a skill you can develop in many ways. I think I developed it like trying to stop young children from killing each other. But you could develop it in, I know there's like some people do like stand-up comedy classes, or MIT has like actually a creative writing class that they offer technical students so that you understand like stories have beginnings, middles, and ends, right? And technical work also needs a beginning, middle, and end. Because if I don't understand why this was a problem, I don't care that you solved it. And if your work seems like it's in isolation, it's not in conversation with the other like 100 super intelligent people all over the world working in this space, why am I reading it? And I think like really focus in on like you're part of a community, right? Like this is a community. Like these are going to be your colleagues. They're people who, you know, hopefully knock on wood, you'll know for the next like 40 years of your life. You'll ask for advice, you'll send your students to them, like that's sort of the goal, right? Like you want to be a person whose work is in conversation with others in this area. That's it.
Thanks, Marzyeh. Yeah, I don't think we can end even better than this question. Thanks, Marzyeh, for share your personal story and share your secret with our students.
Ha
And
ha ha, that's right. Now you can all do the same thing. You're going to be really disappointed, Jameel, when they all take a stand-up class together and then you have to take like
yeah, that's actually a secret we should all practice.
we should, right? Like I think, you know, nobody wants to listen to something boring. Even if it's really smart, you're like, oh, I'll just read the paper. I don't want to hear this. Like, this is so boring. Like, I mean, people like stories. So tell a good story. All right. Thank you for inviting me. I'm going to go teach. And it's always nice to see you, Jameel.
Same here. Thank you.
Bye.
Bye.